Yes, I am here. صوت واضح.
Yes, I will send the scenario in the group. Please read it carefully. Try to write some notes. Okay. And we'll give you 3 minutes to prepare. Then we will start. Actually, someone previously asked me to do the Huntington and genetic counseling. I don't know if this was Dr. Tariq.
Yes, it was ordered by me.
Yeah. Actually, I decided to do multiple endocrine neoplasia for 2 reasons. The first one is it's a very common scenario in the exam, appeared in Diet 1 2020. Okay, counseling for multiple endocrine neoplasias. The second thing, the general approach for both or for any genetic disease is the same. So we will cover this common scenario because it appeared in the exam, and I expect this scenario to appear in the next diets also. So we will cover this scenario, and then we will have a nice discussion to apply the same approach for discussion related to Huntington disease. And hopefully we will be able to clear every confusion regarding both scenarios.
Appreciate it.
And hope all of you also will not get tired. Okay. So Dr. Fazman will start after 3 minutes, okay? Sorry, we will give you only 2 minutes.
Dr. Hussam?
Someone is asking about 4 C's. The first C is clinical presentation. Second C is the cause of the disease. Okay. Third C is complications. Fourth C is coincides or associations. If there is any association related to that disease, you have to search for it. In this way, you will cover all the session and you will get the full mark, hopefully, inshallah. Yes, Dr. Time Fatima, time up. Are you ready?
Okay.
Yes, just let me start the timer. And 1, 2, 3, and go.
Okay, good evening.
Good evening, doctor.
Okay, I am Dr. Ibrahim, the doctor of the endocrine clinic for today. Am I talking to Mr. Robin, 30 years old?
Yes, doctor.
Okay, Mr. Robin, nice to meet you. Mr. Robin, we are here today to discuss some issue related to your health condition. Is that okay with you?
Yes, doctor.
Okay, Mr. Robin, do you want Anyone to attend the meeting with us?
No, I am alone, doctor.
Okay, that is good. Okay, Mr. Robin, may I know how much you know about your health condition?
Yes, doctor. I actually have suffered a painful lump in my neck, and then I thought medical advice. They did some blood tests for me. They ordered a scan for my neck, and then they took a snip using a needle from my neck. And I was surprised that they told me that you have a cancer in my neck. This was horrible, doctor. So they did a surgery for me to remove the gland in the front of my neck. And then I think they took a blood sample to look for whether if there is any something which runs in the family. And I'm here to know the test result, doctor.
Yeah, Mr. John, I'm really sorry for what you are suffering. Do you have any expectation about the result of this genetic test?
Not really, doctor. I'm just afraid that anything might affect my family, or so. I don't want them to go through the horrible experience of surgery and cancer and so on.
Yes, Mr. Robin, I'm really sorry for that one. And as you mentioned, we took blood test from you to test for the genetic, and actually the result is not like we hope.
Oh my God, doctor!
Yeah,
don't tell me
really
that this is something which runs in the family. You mean?
Yes, I'm really sorry to tell you that it is a condition that run in family.
Oh my God! Oh my God! This is
I'm
very
really
bad, doctor.
sorry for.
What does this mean, doctor?
Yeah, it reveals that you have the condition that is called multiple endocrine neoplasia type 2. Do you have any idea about this one before?
Looks complicated, doctor. What is this long name?
Yeah, if you want, I can explain for you more about this. It is a name of a medical condition in which there is a tumor that affects multiple glands in your body. One of that one is your the gland in front of your neck that already removed, and also it's affecting the gland above your kidneys. And also,
Oh my God, doctor. So again,
yeah,
I have to
I'm really sorry
go
for that.
for surgery to remove the glands in my tummy.
At the time being, we will assess you first. At the time being, no need, okay, according to your health status, okay. If you want, if you give me a time to explain for you more about this, okay. As I mentioned, it affects the gland in front of your neck that already removed, and it affects the gland above your kidneys that can present with symptoms of high blood pressure and headache and awareness of your heartbeat, okay, excessive sweating,
Okay.
and you that you will become
But
anxious or having some
doctor, I do not
shaking
have
of the
any
hand.
symptoms related to this this
Yeah,
problem you
that is good.
mentioned.
That is good. So I'm telling you about what the symptoms you may experience in the future if related to this gland. Okay, and
Okay.
you will be followed by multidisciplinary team and from the form of the gland doctor and renal doctor. They will do for you regular checkup, okay, for your renal function and your blood pressure, okay, and according to that they will decide if you need surgery or medical treatment at the time.
Okay, doctor.
Okay, is that okay with you, Mr. Robin?
I don't know. I'm struggling to
Yeah,
understand, doctor. But I'm definitely going to develop these symptoms, doctor.
yes, you may have to. You may develop these symptoms in the future. Okay, so as I mentioned, you have to be aware about that, and you have to be in a regular follow-up with the multidisciplinary team. Okay, and as I told you, it is a genetic condition that is being run in family. So we need also to involve the genetic doctor. Okay, if need to screen your family member as well.
Okay, doctor.
Okay,
So,
Mr. Robin, may I?
I'm just concerned about my brother, doctor. Will he develop the cancer also, or what are the chances that he might get the condition?
Yes, Mr. Robin, as it is autosomal dominant condition, that means 50% of your brother have the chance to get the disease.
I have only one brother, Doctor.
Yeah, so he has 50% chance to get the disease.
Okay.
Okay.
So, yeah, continue, please, Doctor. Yeah, just
Yeah.
wondering about what could be done to ensure that he did not get the disease already. I'm afraid that he might be developing cancer. I don't know.
Yes,
Is that a chance, Doctor?
doing all that. Yeah, he has a chance 50% to have the same disease. So we have to involve genetic doctor and refer him to genetic counseling doctor, and this is his decision to discuss with him this issue. And if he want to do this genetic test, it is according to his decision. If you want to
Okay,
do
Doctor, but
screening.
surely he would want to do this genetic test if it will reveal a cancer that might danger his life. So apart from this
May I
genetic test,
know?
anything you...
Yes, Mr. Robin. May I know how old is your brother?
He's 25, Doctor.
35?
25. 25.
25. So he has the right to accept or to refuse to do this genetic test. So we will arrange a meeting for him.
Yeah,
Okay.
I know, Doctor, he has the right to accept or refuse the test. But my concern is what else we can do in order to prevent the development of cancer. This cancer, Doctor, you can never imagine how difficult it is. I have went through all this. I don't want him to go through this also. What else we can do to prevent this disease happening to him?
Yes, yes, Mr. Robin, I really appreciating your concern. As I told you, because it is a genetic disease run in family. So if he has, if the genetic test came positive, that means we cannot prevent the disease to happen. Okay,
Oh my
but
God.
we can control the symptoms. Yeah, it
oh my
cannot be
God.
preventable. Sorry for that.
Okay, Doctor. This is really very bad, Doctor.
Yeah, I'm really sorry for this bad news for you for today, and I know how much it's hard for you, but I give you the real information that because it is run in family, if the genetic test came positive for your brother, so it cannot be preventable, but we can control the symptoms early and prevent further complication.
Okay, Doctor.
Okay, Mr. Brown, Robin. Okay. May I know
Doctor, I have got a
with whom you are
concern.
living?
I have got a question, Doctor. I am planning to start a family soon, and I am really afraid now that since you told me this condition runs in family, I am really afraid that it might affect my future kids. Any way that I can prevent this disease from passing to my future kids?
Really sorry for
This question
that,
is really
Mr.
important to
Robin.
me, Doctor, because I need to
Yes,
decide whether
I
to have
know.
kids or no.
Yes, I'm really sorry to tell you that also your kids will have 50% the chance to get the disease.
Oh my God. Oh my God.
Yes,
So
I'm
better
really
not
sorry
to
for
get married, Doctora?
that. No, it is not like that because we can refer you to the genetic counseling
Doctora, this is
doctor
very
and he
dangerous. As soon as they
will
develop
sit with
this
you. Yes.
familial condition, there is a chance that they will develop a horrible cancer, which might endanger their life. Okay, and I have no option to prevent this from passing to my future kid. So better to save them the suffering and the surgeries. Better to adopt a child, maybe.
Yeah, it is one of the choices, but we can sit with the genetic doctor. Okay, maybe he has some solution for this by genetic selection. To select the, I mean, to select the gene that not
There is
containing
option,
the.
Doctor. There is another option, Doctor.
Yes, I think we can refer you to the genetic doctor. He is better than me in this. Okay.
Okay,
But
please,
as I know,
Doctor.
there is some genetic selection that can be done also.
Okay. Okay, this is good, Doctor. Please refer me to the genetic counselor now.
Yes, of course.
Okay.
Okay, Mr. Robin, may I know with whom you're living?
I live with my brother only, Doctor.
Okay. And do you need any help at home or
No, I am fine.
social support?
I'm fine, Doctor. I am fine, doctor. Thank you.
Okay, good. That is good. Okay, do you smoke?
Yes, I do smoke, doctor.
Okay, I would like to advise you to stop smoking because it is not good with your condition. And if you don't mind, I can refer you to the smoking cessation clinic to help you about that.
If it will worsen my condition, I will start, doctor. I do not need help regarding this. Is it related to my condition?
Yes, it can worsen your condition because this any malignancy can getting worse with smoking. Okay, and as I told you, the tumor above your kidney that can cause high blood pressure also. This is get worse with the smoking.
Okay, doctor. Then I will think about stopping smoking then.
Okay, thank you so much. Okay, and what are you doing for a living?
I work in the local supermarket, doctor.
Okay, and do you have any trouble at work, or does this disease affecting your work?
No, I am coping well so far.
Okay. So, Mr. Rubin, I would like to ask you if you have any other concern.
So far, I don't think there is any, doctor. Nothing comes to my mind.
Okay. Okay. I would like to summarize for you
So
that
2 minutes remaining.
Yes, I would like to summarize for you that you have been suffering from swelling in the front of your neck, and you underwent surgery, and then discovered to have medullary thyroid cancer, and then we sent for your genetic test that showing that you have a condition called multiple endocrine neoplasia. That is a genetic condition run in family. So 50% of your brother have the chance to get the disease, and also your kid in the future. And we discussed that you will be managed by a multidisciplinary team in the form of renal doctor, gland doctor, genetic doctor. Okay, and you will be followed regularly in outpatient clinic basis. I would like to support you with further leaflet, brochures, and website about this condition to read more. And if you have any query or question, I will give you the contact number of our department, and don't hesitate to contact us at any time. Is that okay?
Okay, doctor.
With you?
That sounds good. Thank you.
Okay.
You have got 1 minute.
1 minute?
Yes. 50 seconds now. Anything you'd like to add? Okay, so we'll give you 40 seconds to recap yourself before the examiner's question. Try to collect your thought and ask yourself whether there is any legal or ethical issues surrounding the scenario. Anything you would have done differently. Okay, so doctor, what's your scenario about?
Explain the result of the genetic test.
Your voice is not clear, doctor.
Explain the result of genetic test and multiple endocrine neoplasia.
Okay, so how do you think your scenario went?
It went more about genetic counseling.
Okay, so how do you think your scenario went? Were you able to fulfill your task?
I think so, or I missed something.
Okay, we will get to discuss this. So any legal or ethical issues surrounding this scenario?
Legal issue, I think the genetic test for his brother.
You mean consent for genetic
Yes.
testing? Okay, what else?
Only this is the legal issue here.
Confidentiality, right? When it comes to consent for genetic testing, confidentiality is very important. Okay, so but if you have the chance to sit again with the patient, any aspect of the consultation you would have done differently? Hello?
Yes.
Yes, doctor. If you have the chance to sit again with the patient, any aspect of the scenario you would have done differently? Anything you would like to elaborate more on? Maybe any more points you would have discussed with the patient?
If I don't know if here we can ask about the symptoms of other part of men. I mean, if he has symptoms
This
of
is station 4, doctor.
hyperparathyroidism.
This is station 4. What else you can ask about?
Family history of his parents.
You ask about family history. You ask about his brother. What else? Okay, time up. You can move to the next station. Dr. Fatima, you did great, by the way. If you do the same case in the exam, you will pass, definitely. And I apologize for being rude surrogate and tough examiner, but usually in such cases, you should expect a lot of drama. So we have got some comments regarding your performance. Just because we are seeking perfection, our aim is the full mark, not only to pass the station. Okay, and then also to give you approach for the case and similar scenarios. So when you started, sorry, because I will comment about everything. Okay, when you started the session, you mentioned to the patient, "Good evening." By the way, it's fine to tell the patient good evening, but there is a lot to cover here. And with exam stress, you don't need to occupy your mind with a lot of details, which is not necessary. You can say hello there, okay? Because sometimes you will get out of your home or your flat by 10 o'clock, for the instance. By the time you reach station 4, it will be 12 p.m. Okay, you will tell the patient good morning. He will tell you good afternoon, doctor. This is going to be distressing, and it will give bad impression about yourself. You will not be feeling confident starting the session. So instead of good morning, good evening, good night, just say hello there. Okay, is it Mr. X? My name is Dr. Tahir, one of the doctors in the clinic today. The same thing. Do not mention in the gland clinic, heart clinic, gut clinic. It is fine to mention this, but why to mention when it is unnecessary? You can keep it simple. I am one of the doctors in the clinic today. Okay, hello there. Is it Mr. X? I am Dr. Tahir, one of the doctors in the clinic today. Okay, so then you did very nice in asking about the patient background and exploring his ideas and concerns. So the patient mentioned a lot of informations. You need to appreciate this. Well, you seem to have a good knowledge of your condition. Thank you for sharing this with me. Okay, and I was happy that you did not repeat the information that surrogate mentioned to you. Some of the candidates, they will ask the patient about his background. The surrogate will tell him, I have got painful neck swelling, and then I did blood test, imaging, they took a snip, and then they told me you have cancer. I went for surgery, now I am fine. They did a blood test for genetic testing, and I'm here for the result. Then again, he will start to tell the same thing to the surrogate. Sorry, mute, please. Mute, Dr. Muhammad Diab. Again, he will start purposely purposelessly to repeat the same information to the surrogate. Just a matter of wasting his time. Okay, Mr. Brown, you told me that you have got painful neck swelling and you have did blood test and imaging and you did surgery. This is nonsense, okay, and very bad thing to do in the exam because you are just wasting your time, okay, and it is very irritable to the surrogate because he have got some concern, which he just mentioned to you that he want to know the genetic test. So why wasting time repeating the same information which the surrogate already mentioned? Okay, so I was really happy that you did not do this bad mistake. Okay, you went ahead. You filled the gap in his knowledge. Okay, then you gave a very nice warning shot and you break the test. Okay, but when you told the patient you have got a medical condition called multiple endocrine neoplasia type 2, he told you, "Oh my God, doctor, what is this long name? Seems complicated." You should apologize here. Sorry for the long name. Let us call it MEN2 for short. Okay, it's okay if you do not do this, but you will seem very professional and good communicator. Okay, your surrogate explain that it's annoying, this very long name I cannot remember, so you have to offer solutions. Sorry for the long name, let us call it MEN2 for short. Okay, then go on and ask him, would you want me to explain further to you? You have to take his permission. Okay, then he will tell you, yes, please go ahead, doctor. Here you should start with drawing. I do not know, after all this skills, you have a very nice communication skills, but I do not know why you did not draw, Dr. Fatima. You should draw whenever you try to explain any disease or any procedure, because as soon as you start drawing, you will have explained the anatomy, pathophysiology. Information will keep flowing to your tongue naturally and without even thinking about them. Okay, so drawing is really very important, and examiners like drawing very much. Okay, imagine that you started drawing. Let me draw you a very simple drawing. It will help us explain the situation. Okay, then you will just draw something like this. If you can, just a moment, I will share my screen. So let me draw you a simple drawing just to make it clear for you. Are you able to see my screen? Hello?
Yes.
Are you able to see my screen?
Yes. No.
Okay.
Coming now.
So, what was his name, Mr. I forgot the patient name. Robin. So, Mr. Robin, this is the major gland in your neck. It is called the thyroid gland. Okay. Behind this thyroid gland, there is 4 small glands called the parathyroid gland. And in your tummy, there is 2 glands situated above each kidney. The name of this are the adrenal glands. Okay, now you explain the anatomy. Okay, these glands secrete hormones which control some of the functions in our body. Okay, this is pathophysiology. In people with MEN2, okay, there is a faulty gene which runs in families, which runs down in families from one generation to the next. This faulty gene will increase the chance of growth development in these glands, in one or more of these glands. Did you get that? Okay, there is a faulty gene which runs down in families from one generation to the next. This faulty gene will increase the chance of growth development in one or more of these glands. Okay, if you explain it this way, he will not tell you, doctor, but I do not have any symptoms suggestive of pheochromocytoma and so on. I do not have any high blood pressure. No, I already told you that it might result in growth in one or more of the glands. Okay, this growth might be or might not be a cancer. Okay, in your case, you develop a cancer in the glands at your neck. That's why they needed to remove it with surgery. Okay, so by now you explain the anatomy, pathophysiology, the cause, which is familial, or autosomal dominant, okay? And you explain also part of the clinical presentation, okay, which is cancer. And you related this clinical presentation to the patient condition, okay? So almost you covered all your C's. You covered the cause, autosomal dominant. You covered the clinical presentation. For this particular patient, it was medullary thyroid cancer, right? And then you covered clinical presentation cause and some of the complications. Actually, thyroid cancer here is regarded as complication also. It can be as complication. Okay, so the remaining part is to explain other clinical features related to multiple endocrine neoplasia. Okay, sometimes this growth might affect the adrenals, which are these glands, or the parathyroid, which are the small glands behind your neck. Okay, this growth, if it affects the adrenals, it might result in symptoms like high blood pressure, heart racing, flushing, and so on. If it affects the small glands behind the major gland at your neck, it might result in increase in a salt called calcium in the blood, which may result in sorry, which may result in excessive urination, hard stool, headache, high blood pressure, and so on. Okay. By now, you explain complication, clinical presentation, cause, and everything already explained. Okay. So the time now is for explaining the management plan. Patient will be frustrated, fearful, worried. Okay. Doctor, so am I going to develop these problems also? Will I need another surgery? Okay. I am sorry to tell you that it is possible that you develop one of these problems in the future, Mr. Robin. For that, our consultant has decided a management plan. Okay, here he was disappointed and fearful and worried. So as soon as you mention the management plan, tell me, doctor, please, what management plan? Before we go further, Mr. Robin, I would like to ask you a few questions. It will help us, not help me. Inclusive approach. It will help us outline the management together. Always try to use inclusive approach. Okay. It gives a sense that you are keen, you are a professional communicator. Okay. When you involve the patient in outlining the management plan, the examiner will be very happy if you mention this way. So before we go further, I would like to ask you a few questions. It will help us to outline the management plan together. He will tell you, sure, doctor. So at this point, think about every possible information regarding clinical judgment. Okay, with whom do you live, Mr. Robin? Have you got any financial struggles? Okay, if he has got. So, Mr. Robin, I will post your name to the social services. We can see if they can help in this matter. Do not tell him they will help you in this matter. Social services will not give him money for free, right? But they will try to help him. So I will post your name to the social services and see if they can help regarding this matter. So here, the examiner will give you your marks in the clinical judgment regarding social help. Okay, so the next question will be, do you smoke, Mr. Robin? Sorry to tell you that smoking might increase the risk of cancer in general. Okay, so it's really important to stop smoking. Okay, you have to mention this way. You told him you have to stop smoking, then he had to ask you whether smoking is related or not. No, don't wait for the patient to ask. He will consume your time. You should mention, okay? You have to stop smoking because smoking increases the risk of cancer in general, and already you have a risk of cancer. Okay? So then do you drink alcohol? Moderate your alcohol. Trying to call me just a moment, I will be back. Okay, so just to recap, before you start the management plan, ask about social history, any financial struggle, so offer help. Do not ask any history in station 4 unless you will provide help. Okay, social history to provide help only. Okay, financial struggles to provide help. Okay, then smoking, advice to stop smoking, alcohol, moderate alcohol intake. Okay, then uh, you can ask at this stage about any siblings. If he has got any siblings or any kids, you have to bring them for screening. This is very important, and I cannot stress more on this. If you do not advise screening for the family members in someone who has got multiple endocrine neoplasia, your clinical judgment will be devastated. You will lose a lot of marks in clinical judgment, because any patient who has got multiple endocrine neoplasia type 2, if you do the genetic testing for his family member and they tested positive, you have to they have to go for prophylactic thyroidectomy before they develop cancer, because if they do not go for prophylactic thyroidectomy, definitely they are going to develop cancer of thyroid glands. So you have to ask about any siblings, any kids. If there is any siblings or kids, I advise you, Mr. Robin, to bring them to do the genetic testing, okay? Because there is very high chance of developing cancer, and if the genetic testing was positive, they might go for the same surgery to remove the gland before they develop cancer. Okay, so this is the way to answer his concern. He kept repeating, will he go through the same problem, doctor? Will he develop the cancer? You kept telling him that yes, if he got the genetic condition, he will develop cancer, but you did not solve the situation. You have to tell him that in case he tested positive for multiple endocrine neoplasia type 2, he will go for prophylactic thyroidectomy before he developed the cancer. Is that clear, Dr. Fatima? Is this clear, Doctora? Hello?
Yes, Dr.
Is
Hussam,
my...
yes.
Okay, my voice is clear, right? Okay, so
Yes.
just to recap, before management, you have asked, you should ask these 4 questions: social history, smoking, alcohol, ask about siblings for screening, and ask about if he has got no kids now, ask him, are you planning to start a family soon? Do you plan to get pregnant soon if she was a female? Okay, do you plan to have kids soon? In case he asks you, he tell you that yes, I plan to get kids soon, tell him, as we have discussed. Do not mention to the patient that, as I told you. As I told you is a little bit rude, Dr. Fatima. You mentioned this once.
Okay.
I have wrote it down. As I told you, زي ما أقول أنا ما زي ما قلت لك أنا. It's a little bit harsh even if you translate in Arabic. So as we have discussed, okay, as we have discussed, Mr. Robin, this type of disease runs in the family, and each one of the offspring has 50% chance of developing the disease. Okay, so I will refer you to the genetic counseling, to the genetic counselor. Okay, there is some options we can use to prevent the disease transmitted to your future children. This will be discussed in details with the genetic counselor. Do not mention what options they are going to suggest. This is for the examiner discussion in case he asks you. Okay, but for the patient or for the surrogate, this will be discussed with you in details when I refer you for the genetic counselor. If the examiner asks you, they can do embryo selection and IVF. They will choose a sperm and egg which does not carry the bad gene. Okay, they will do the fertilization and then in vitro implantation. Did you get that? So embryo selection and IVF. Other options include amniocentesis or embryonic villus sampling to check for the bad gene. I mean, if they tested positive, then they will do abortion. Just in case already pregnancy is happening. They will take a sample from the amniotic fluid surrounding the baby, or they will do embryonic villus sampling, they will test for multiple endocrine neoplasia type 2. And if it was positive, there is option of abortion. The third option is adoption. If this failed, they can do adoption. So 3 options: embryo selection and IVF, amniotic villus sampling or embryonic villus sampling or amniocentesis, okay, genetic testing, and if positive, abortion. The third option is adoption. Okay, they can adopt a child. Okay, if they do not want to go through this dilemma. So just to recap again, you did the drawing, you explain the anatomy and pathophysiology, you explain the cause, which is autosomal dominant, you explain the clinical picture and complication. Okay, then you go on to the management plan. Before you go to the management plan, secure your clinical judgment. Ask about smoking, alcohol, I'll give advice, social history, financial struggles, give advice. Ask about any other family members. If there is any siblings or kids, advice screening. And if positive, they will go for a prophylactic thyroidectomy. Otherwise, if there is no kids, ask him whether he is planning to have kids in the future. If he is planning, genetic counselor referral to discuss options of preventing transmission of the disease to the offspring. Okay, so when you reach this point, everything is almost covered. Everything. Okay, you will come to the rest of the management plan at easy. You will just repeat the information you are saying for every patient or every surrogate. We will form a group of doctor, multidisciplinary team. This group of doctor will include, okay, the multidisciplinary team should be tailored according to the case. In this case, we have cancer, so it will involve the cancer doctor, oncologist. It will involve gland doctor, endocrinologist. Okay, it will involve surgeons, and so on. Try to mention the group of doctor which will be formed, social workers, and so on. We will keep you on regular follow-up. And regular follow-up, Dr. Fatima, is for 2 purposes. The first one is to make sure that cancer is not going to recur again in the future. Okay. When you explain to the patient, you explain the clinical picture, you mention some of the complications. Complications is that you might develop another gland infection or the cancer might recur again, right? So in the follow-up, follow-up is for 2 problems. To make sure that the cancer will not recur again. How are you going to do this? By doing calcitonin, okay, and carcinoembryonic and carcinoembryonic antigen annually. They will do annual carcinoembryonic antigen and calcitonin. Calcitonin is a hormone secreted by the C cells in the thyroid. C cells. C cells of the thyroid is the origin for medullary thyroid cancer. Okay. This hormone in normal persons has got no function, no known rule. Okay, but it is very useful in monitoring recurrence and development of medullary thyroid cancer. Okay, so to screen for recurrence of the cancer, calcitonin level and carcinoembryonic antigen annually. Okay, how to screen for the development of other gland infection? For pheochromocytoma, you will do 24-hour urinary catecholamine levels, and if this is high, you will do MRI abdomen, PET scan, or MIBG. Allah la jabul MIBG. So methyl isobenzyl guanine scan. Okay, and if adrenal tumor was detected, they will go for surgery. 70% of cases, the tumor is bilateral, so they will do bilateral adrenalectomy. Okay. Okay. The other component is the parathyroid. If you develop any symptoms of hypercalcemia, you will do serum level for calcium and parathyroid hormone. So you do not need to mention all these details to the surrogate. Try to keep it simple. Okay, we will keep you on regular follow-up to make sure that cancer will not recur again, and to make sure that you will not develop any other gland infection. This is usually done by blood and urine test, full stop. Blood and urine test, full stop. If you see all the investigation I have just mentioned, all of them are blood tests, except 24-hour urinary catecholamine level for few chromocytoma. It will be done from the urine. So he is not a doctor. Do not mention all these excess details. This is for discussion with the examiner. Okay, we will keep you on regular follow-up to make sure that cancer does not recur again, to make sure that you will not develop any other gland infection. And this is usually done by a blood and urine test, full stop. Okay, then you can, if you have time, you can offer some warning to the patient. If you develop in the future any symptoms like high blood pressure, heart racing, panic attacks, any flushing, any excessive urination, headaches, high blood pressure, any weight loss, any change to appetite, please report to hospital for assessment. If you do this case this way, I can assure you 100%, Dr. Fatima, you will get the full mark in the exam. Okay, so is it clear so far? Regarding
Dr.
the
Hussam,
approach,
can you please repeat for the options to prevent the transmission to the siblings in the future?
okay, so we have got 3 options. The first option is embryo selection and IVF. Embryo selection and IVF. The second option is embryonic villus sampling or amniocentesis, then genetic testing. If positive, abortion. The third option is adoption. They can try and adopt a child. Okay, but do not mention this to the surrogate. We have mentioned this is for discussion with the examiner if he asks you. But for the surrogate,
Okay.
I will
In case
refer you to the
surrogate ask
genetic
how I
counselor.
can prevent this, yeah, we will refer
Yeah.
we will told him that we will refer you to the genetic counselor
To
only.
the genetic counselor, he will discuss the options with you in details. Full stop. Do not overload him with a lot of information. Anyway, by the end of the meeting, you will offer him, as Dr. Fatima did, you will offer him brochures, support groups, websites. He can read at home at his own pace. He can read anything. Okay, do not overload him at this single meeting. Okay.
And in case the surrogate ask, as you ask, that how I can do so better if I am not married, what I will reply to them?
I did ask Dr. Fatima this because she kept telling that it's a genetic condition and it is definitely going to pass to your children. So I wanted to make it a little bit harder for her because this was not the right way to answer the concern. But if you tell him that there is some ways to prevent the transmission to his future children, he will not tell you that I will not get married, right? Did you get that?
Yes, yes.
Yeah. So any question regarding the approach? Hope the approach is clear. Regarding
Dr. Hussam,
neoplasia itself, yes.
Dr. Hussam, surrogate was repeatedly asking that whether my brother will have this condition, brother will have this condition. If he had this condition, he could have suffered same which I had.
The same thing. You have to reassure him that if he tested positive for multiple endocrine neoplasia, he will go for prophylactic thyroidectomy before he develops the cancer. So he will not go through the same horrible experience you have been through. Did you get that? Dr. Fatima, because I wanted her to mention this point and she did not. That's why I kept telling her, will he develop the same cancer? Will he develop the same problem? This cancer is horrible. Anyway, to prevent this, I wanted her to mention prophylactic thyroidectomy. Did you get that?
Yes, and should we explain him genetic pedigree that 50% of your
yes,
siblings will have chance?
You can mention also, yes, each one of the offspring have 50% chance of developing the condition.
Okay, thank you.
Welcome. So hope the approach is clear. Any problem has got any? Sorry, mute, please.
There is any chance that this genetic test can be false positive or something like this?
Sorry, come again, please.
There is any chance that this genetic test we did for like genetic or familial disease can give us like false positive results? So we can discuss that with the surrogate.
We are going to discuss the genetic testing. Just now, I would like you all to tell me whether the approach-wise, this case, is the approach clear or not? Because genetic testing and multiple endocrine neoplasia itself and Huntington disease, we are going to discuss later. But for now, I want you to get a clear picture about the approach. I mean the drawing, anatomy, physiology, the 4 C's, okay? How to save your clinical judgment, how to explain the plan. Approach-wise, is it clear?
Yes.
Clear.
Okay, so just I will mention the possible concerns as we have, as with Dr. Fatima. The patient or the surrogate might be concerned about his future children, his family, any way to prevent passing the disease to his future kids, any way to prevent the development of cancer in other family member. Okay, how can we make sure that I do not develop any other gland affection in the future? Will the cancer recur? Any chance that the cancer may recur in the future? And the answer to this question, yes, there is a chance. If the thyroid gland was not fully removed, there is a chance that cancer will recur again. Okay, and in this case, carcinoembryonic antigen and calcitonin both will be high. So there is a chance, but we will keep you on regular follow-up to make sure that you do not develop this recurrence. And if you develop recurrence, we will treat you accordingly. Okay, sometimes if there is time, the surrogate might ask you, doctor, I have got some itching in my back. Is it related? Or shall I visit a skin doctor? So people with multiple endocrine neoplasia type 2 develop something called CLA, cutaneous lichen amyloidosis. Cutaneous lichen amyloidosis. It will be like thickening of the skin, maculopapular thickening of the skin at the upper back between the scapulae, and it will be extremely itchy. This is very rare and did not appear in the exam before. Just put it in your mind that if the surrogate asks you, I have got itchy skin rash, is it related? Tell him yes, it is related. Okay, so these are all the possible concerns which might be raised by the surrogate. So I will mention just few points regarding multiple endocrine neoplasia type 2. Okay.
Dr. Hussam, sorry to
yes.
ask this question. One of the concern of the examiner, the
Yes.
diet 3/2021, he asked that does the husband have a right to know about this his wife condition because she want to marry, and he is asking that the husband have a right to know about his.
No one has the right ever to know about anything regarding her medical condition unless he agree. Okay, you should advise her that it will be better if you tell your husband, and if you want me to be in the meeting to explain, I will be there, he will support you, and blah 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 blah. But if she deny telling her husband or her fiance or her boyfriend, you have no right to breach confidentiality, because there is no dilemma or there is no conflict with public interest. Okay, he will not going to develop HIV or hepatitis B or C. He will not get harmed anyway. Just the issue of future kids. Okay, and there is some solutions for this matter. Okay, so you will advise her to tell her husband. Okay, you will offer that I can be attending the meeting to explain the issue further, to help you explain to your husband. But if she do not agree, you cannot breach confidentiality. Is that clear?
Yeah, clear, Doctor. Thank you.
Okay. So, what are the components of multiple endocrine neoplasia type 2? The most common problem is medullary thyroid cancer. Medullary thyroid cancer happens almost in all patients. Can you imagine? Almost all patients, more than 95%, will develop medullary thyroid cancer at some stage during their life. By the age of 40, more than 95% will have developed the cancer already. Okay, so the first component is medullary thyroid cancer. Okay, the second component is pheochromocytoma. Pheochromocytoma happens in almost half the patient. It is 30 to 50. 30 to 50. So in average 40%. This is regarding pheochromocytoma. The third component is parathyroid hyperplasia. Parathyroid hyperplasia, it is very common up to 80%, but not all of them will develop symptomatic hyperparathyroidism. Okay, only 20% will develop hyperparathyroidism. Although, if you check, all of 80% will have thyroid hyperplasia. Did you get that? So the component is medullary thyroid cancer, 95%, pheochromocytoma, 40%, parathyroid hyperplasia, 80%, but only 20% will develop hyperparathyroidism. Okay, so what is the difference between multiple endocrine neoplasia type 1 and multiple endocrine neoplasia type 2? Okay, the difference is usually in multiple endocrine neoplasia type 2B, they will be mucocutaneous as well as musculoskeletal affection. They will have marfanoid body habitus, skin neuromas, and so on. Multiple lesions in the skin, mucous membranes, intestine, marfanoid body habitus, and so on. Okay, usually these are not common in multiple endocrine neoplasia type 2. Okay, other difference is medullary thyroid cancer usually happen early and tend to be more severe in 2B rather than 2A. Okay, and the prognosis tends to be worse also in 2B compared to 2A. Okay, one more difference is that parathyroid hyperplasia usually happen in 2A, but it will not happen in 2B. Is that clear? So the first difference is musculoskeletal and mucocutaneous difference. It will happen in 2B, not in 2A. Okay, then hyperparathyroidism and parathyroid hyperplasia, it will happen in A rather than B. Okay, cancer, thyroid medullary carcinoma will happen early, and it will usually tends to be aggressive in 2B compared to 2A. Okay, so if I ask you, what are the types of surgery usually done for people with multiple endocrine neoplasia type 2? Dr. Fatima, the question is for you. What are the surgeries usually done for MEN2? Any idea?
What surgery you mean? I cannot. What's the question?
Any type of surgery. I'm asking this question, by the way, to be able to take a sip of water. So, any type of surgeries you are aware of for people with multiple endocrine neoplasia type 2? Already we have mentioned one, right? Which is the thyroidectomy.
Yes.
Whether for cancer, which is medullary thyroid cancer, or prophylactic thyroidectomy in people who test positive for the condition. Other surgeries, yes, bilateral adrenalectomy, but only if thyroid is already removed. If the patient is going for thyroid surgery and he has a pheochromocytoma, okay, and you did thyroid surgery before adrenalectomy, he will die on table because pheochromocytoma increase the risk of death during surgery. So they should do bilateral adrenalectomy first, okay, and once there is no any pheochromocytoma, then they can do the thyroidectomy, whether it is therapeutic or prophylactic. So two types of surgery: thyroidectomy, whether prophylactic or therapeutic; bilateral adrenalectomy, which should be done before any other surgery if the patient has got pheochromocytoma, and then parathyroidectomy. But parathyroidectomy will usually be done only if there is hypercalcemia. Otherwise, at the time of thyroid surgery, if the parathyroid glands were found to be enlarged, then they will be removed also. Okay, but only for parathyroid hyperplasia, you will not do surgery. It has to be symptomatic hypercalcemia or enlarged glands found during thyroid surgery. Okay, so these are the types of surgeries usually done for multiple endocrine neoplasia type 2. So regarding the most sinister complication in MEN2, I mean medullary thyroid cancer. If we would like to cover medullary thyroid cancer, what are the clinical presentation? Usually, like any cancer, okay, symptoms due to the tumor itself, symptoms due to local spread, symptoms due to hypermetabolic syndrome. Okay, so local symptoms for the tumor itself, painful neck lump, painful neck lump. Okay, sometimes you might find swelling without pain, but usually pain and swelling in the thyroid gland. Then symptoms of local spread, lymphadenopathy, breathlessness, dysphagia, dysphonia. Okay, and then symptoms of hypermetabolic syndrome, which are weight loss, loss of appetite, lumps and bumps, night sweat, low-grade fever, and so on. So these are the clinical presentation. So at which age usually medullary thyroid cancer can develop? Medullary thyroid cancer can develop as early as 5 years of age. Usually, as we mentioned before, medullary thyroid cancer arises from the C cells of the thyroid gland, which is also known as parafollicular cells. Okay, these C cells, okay, will lead to development of medullary thyroid cancer, but there is stages. The first stage is C cell hyperplasia. C cell hyperplasia. The second stage is microscopic finding of medullary thyroid cancer. So the patient will feel nothing, but if you take a snip, if you take a biopsy, you will find cellular changes related to medullary thyroid cancer. The third stage is overt medullary thyroid cancer, which usually the patient will develop the symptoms we have just mentioned. I mean, the swelling and pain. And usually by the time of presentation, metastasis to local lymph nodes already happened. Okay, so usually they will do thyroidectomy plus central lymph node excision, as our case in the scenario. If you notice, it is mentioned that he did thyroidectomy with central lymph node excision. So by the time of presentation, usually the lymph nodes already affected. So the first stage, I mean the C cell hyperplasia, can happen as early as 3 years in MEN2A and at birth in MEN2B. We have mentioned that cancer usually happens earlier and tends to be more aggressive in 2B, right? So at birth for 2B and at 3 years for 2A, you can find C cell hyperplasia. Okay, then by the age of 5, microscopic features of medullary thyroid cancer will start to develop. By the age of 15 to 20, symptomatic overt medullary thyroid carcinoma usually develop. By the age of 40, almost all patients, I mean more than 95% of patients, will have developed cancer. So it's really important, as soon as the diagnosis is confirmed, to go for prophylactic thyroidectomy. So how are we going to screen for this cancer? There is different situations. The first situation is the patient already develops the symptoms, like our case here. Already he developed thyroid cancer. He developed the neck pain, neck swelling. He went for surgery and so on. Okay. In this case, as our patient, we did the genetic testing, right? Genetic testing came positive. Immediately you have to call other family members for screening. Okay. If they are positive and high risk, immediately they should go for prophylactic thyroidectomy. Otherwise, if they tested negative or they tested positive but low risk, by the way, genetic testing is not like positive or negative. No, it will come as positive with high risk, negative or positive with low risk. So positive with high risk, immediately prophylactic thyroidectomy. Negative or positive with low risk, you will not do prophylactic thyroidectomy, but will screen them annually for medullary thyroid cancer by doing annual calcitonin level. Annual calcitonin level, okay? You will screen them for pheochromocytoma by doing annual urine, 24 urine for catecholamine levels, okay? You will screen them for hyperparathyroidism also annually by doing serum calcium and parathyroid level, but screening for parathyroid usually is a little bit late, 10, sometimes up to 20 years. You should start the screening, but because hyperparathyroidism usually will not develop unless the patient usually will be at 30th year of life. Okay, so the screening for parathyroid should start a little bit later. at the age of 10 to 20, but pheochromocytoma and medullary thyroid cancer since the diagnosis. So the patient developed cancer, removed by surgery. He is on regular follow-up to make sure that he will not develop the recurrence of cancer by calcitonin and carcinoid embryonic antigen. Okay, he will be screened annually for pheochromocytoma and hyperparathyroidism. The next step is to screen the family, and if tested positive with high risk prophylactic thyroidectomy, tested negative or low risk, they will go for annual screening for the three conditions. Is that clear? So this is the first situation. Is this clear so far?
Yes, please, Dr. Repeat, Dr. Hussam. The screening.
Okay. Okay, regarding screening for multiple endocrine neoplasia and screening for medullary thyroid cancer, we have got few situations. The first situation, the patient already developed the cancer and he underwent thyroidectomy. Okay, in this situation, we'll screen the family if tested positive, okay, or high risk, prophylactic thyroidectomy immediately, regardless of their age. It can be done as early as 3 to 5 years of life. So tested positive, okay, has family history positive, our patient, okay, and high risk, they should go immediately for prophylactic thyroidectomy. Otherwise, if they have family history, our patient which undergone thyroidectomy, but when you test them, genetic testing was negative or low risk, so no need to go for prophylactic thyroidectomy. Instead, annual screening for the three conditions. I mean medullary thyroid cancer, pheochromocytoma, and hyperparathyroidism. Is it clear?
Yes, clear. Shukran.
Okay. The second situation, patient presented to you with other features of MEN2. I mean not cancer. He developed pheochromocytoma or hyperparathyroidism, okay, or he has family history of MEN2. Here you will do genetic testing, okay. If positive, then again prophylactic thyroidectomy immediately, because now MEN2 confirmed and there is very high risk of developing cancer. He will definitely develop cancer if you do not do prophylactic thyroidectomy. So he did not develop thyroid cancer. He developed one of other condition and he has a family history, tested positive for MEN2, diagnosis confirmed, immediately go for prophylactic thyroidectomy. Is that clear? Clear so far?
Yes.
Again, please.
Yes. So the first situation, patient developed cancer already, we screen the family. If positive, prophylactic thyroidectomy. If negative, annual screening. Okay. If the patient has no thyroid cancer, did not develop thyroid cancer till now, but he has other features suggestive of MEN2, okay, and or he has positive family history. So we need a genetic test to confirm the diagnosis. Diagnosis confirmed, prophylactic thyroidectomy at immediately, because otherwise he will develop cancer and die. This is very important. He should go immediately for prophylactic thyroidectomy. Imagine that he developed pheochromocytoma or he developed parathyroid hyperplasia, hyperparathyroidism. Okay, he has a family history, but genetic tested negative. MEN2 did not confirm in genetic testing. So what you will do? Again, annual screening the same way. Did you get that? Did you get the point?
Yes, yes.
Genetic testing
it is not confusing.
negative.
Yeah.
Genetic testing negative, and we will screen.
Usually, if genetic test is negative, you will not do prophylactic thyroidectomy. You will do annual screening. Okay.
Okay. Okay.
So now, hope it is clear now.
Dr. Hussam,
yeah. Yes, please, Dr. Mehwish.
You keep on going.
Okay, you can just memorize the screening as a common sense. Common sense. Because whenever the patient develops MEN2 and the diagnosis is confirmed, definitely he's going to develop cancer. So you will not wait for this cancer to develop. At that time, you will do prophylactic thyroidectomy, right? This is common sense. Imagine that diagnosis was not confirmed by genetic testing. Genetic testing was negative, but there is a suspicion. In this time, it is not necessary to go for surgery. Surgery is invasive, but you can do annual screening. Okay, for the three conditions, whether cancer or pheochromocytoma or parathyroid hormone. Okay, again, it's common sense, right? So if you think about it, by common sense, you can get the answer.
Dr. Hussam,
Yes.
in case we have discussed in station 4, recurrence of cancer will be detected by CEA, carcinoembryonic antigen.
Carcinoembryonic antigen is a tumor marker, okay, which is secreted in 70%.
I know it.
Yeah, 70% of human cancers will increase the carcinoembryonic antigen, whether it is colonic cancer or whether it is medullary thyroid cancer. So it's a tumor marker useful in screening for recurrence of medullary thyroid cancer. The other one is calcitonin. Calcitonin is the hormone released by the C cells. The C cells are responsible for medullary thyroid cancer. Okay, if there is medullary thyroid cancer, calcitonin level will increase. So two tests to check for recurrence. Okay.
And fourth is one for cause, one for clinical feature, complication, and fourth one was
coincides or association. In case
coincides.
Okay. Coincides or association. Yeah. Okay.
What about post-surgical follow-up?
Yes.
Post-surgical follow-up you can do
for medullary thyroid cancer.
Yes.
Okay. Post-surgical follow-up for. Okay, any person who has got multiple endocrine neoplasia type 2 who developed cancer and went for thyroidectomy, you need to do follow-up for two problems. The first one is the recurrence of cancer. This one, calcitonin and carcinoembryonic antigen. Okay. The second one, you need to follow him up for the development of any other gland affection. I mean, pheochromocytoma. This, you are going to do this by annual 24 urinary catecholamine level. Okay. Other gland affection might be hyperparathyroidism, right? So you will screen for this by doing annual serum calcium and parathyroid hormone level. So screening for recurrence of cancer and screening for other gland affection.
Okay.
Okay. Is it clear so far? Hopefully I was able to clear any confusion regarding multiple endocrine neoplasia, the approach. If any question, please do not hesitate to ask. If no questions, we are going to move on to discuss Huntington disease. It will be just a matter of final touch because we already have a grasp on the general approach. We will not do it as a case, we will just discuss. So any question regarding multiple endocrine neoplasia type 2 so far? Is it transparently and crystal clear, please?
Yes.
Apparently.
Okay, so regarding Huntington disease, again, by the way, the same approach apply here. You introduce yourself, okay? You assess the idea, concerns, and expectations, okay? Then you will give him a warning shot and tell him about the diagnosis of Huntington disease. Okay, what is Huntington disease, doctor? Please explain to me. Okay, let me draw you. As soon as the surrogate tell you, please explain to me a diagnosis or procedure, drawing immediately. Drawing, just as we have done in multiple endocrine neoplasia type 2. Let me draw you a simple drawing. Let us assume this is your brain. In your brain, there is some areas which control thinking, behavior, mood, memory, and movement. TB, triple M. TB, triple M. T for thinking. B for behavior. Triple M, memory, mood, and movement. So the symptoms are going to be mental fogs, memory lapses, behavioral changes, like some of them will develop attention hyperactivity disorder, okay? Mood changes like depression, and some of them might commit suicide, anxiety, okay? Movement disorder like chorea, Huntington chorea, okay? And memory lapses. So TB and triple M. Thinking, behavior, movement, mood, and memory, okay? So let me draw you a simple drawing. Let us assume this is your brain. In your brain, there is some area which control our thinking, behavior, memory, mood, and behavior. Okay. In people with Huntington disease, there is a faulty gene which passed down in the family from one generation to the next. This faulty gene will cause these parts of the brain to become damaged over time, which will result in them being unable to function properly, resulting in problems similar to your problems, resulting in symptoms similar to your presentation. Did you get that? So as soon as you draw, you explain the anatomy, you explain the pathophysiology, okay, you explain the cause, you explain the clinical presentation, and you link the clinical presentation to the patient situation. Okay, what is left is the 4C, which is complication. Okay, you do not need to mention all the complications which are written in the textbook. And by the way, people with Huntington disease have problem with thinking, have problem with concentration, have problem with memory. So you do not want to overload them with lots of information. And anyway, by the end of the meeting, you are going to offer support. You are going to offer brochures, websites, leaflets, group support. They can go and read all the necessary information at their own pace. Did you get that? So the 4C complication here, just mention few complications. Okay, you can mention, for instance, I am sorry to tell you that this condition tends to get worse with time. So the first complication is progression. Okay, the second complication you can mention here is anticipation, because it is catch repeat, right? Anticipation, I mean, usually the next generation will develop the medical condition earlier, and it tends to be more aggressive. So in order, how you are going to mention the complication? I am sorry to tell you that this disease tends to get worse with time, progression. And the next generation usually will develop the disease earlier, and it tends to be more aggressive and more severe. Okay, by this time, the patient worries and fears, and his concerns will be boosted to the roof. He will be very worried. Oh my God, doctor, seems very critical. Am I going to die, doctor? Any treatment? Is it treatable? Okay, Mr. David, I'm sorry to tell you that it is not treatable, but we are here for you to help you. We are here for you to provide support, okay? And our consultant already suggested a plan for management, okay? Then he will ask you, what plan, doctor? Tell me, please, I would like to know. Then, as usual, before we go further, I would like to ask you a few questions. It will help us to outline the management plan together, inclusive approach. Okay, I would like to get more of a picture about your social background and social life. Okay, with whom do you live? Any family member affected by the condition? Maybe he will tell you, my father also, doctor, he has got the same condition, because this is running in families, right? So maybe he will tell you, my father, he has got the same condition, doctor. I don't know how I'm going to care for him in the future if this problem got worse. So immediately we have agreed that any question asked, you should offer help. If the question you are going to ask, okay, will not help you to offer help and aid in the management plan, do not ask. Okay, so if he mentioned any social problem, I will signpost your name to the social services. They will try and help you regarding this issue. Do not give false hope. They will help you. They will come to your home. They will take care of you and your father. They will give you money. No, this is not real. This is not happening on the ground. So I will signpost your name to the social services. We will see if they can help you in this regard. Okay, this is the first question, social. Then smoking. Okay, smoking is bad for health. I advise you to stop smoking. Then alcohol. And alcohol here, you should link to Huntington, because there is studies linked excessive alcohol drinking to worsening of Huntington disease. So, Mr. David, I advise you to moderate your alcohol consumption, because alcohol is known to make Huntington disease worse. So it is really important to moderate your alcohol consumption. So social, smoking, alcohol, driving. Here, it is not like multiple endocrine neoplasia type 2. In multiple endocrine neoplasia type 2, nothing to suggest to stop driving, okay? In neurofibromatosis, unless the patient has got optic glioma, problem with his vision, you do not need to stop driving. But in case of Huntington disease, there is a lot of neurological problem, okay, which will not allow the patient to drive safely. So, Mr. David, I really advise you to stop driving because it will put you and the public at considerable risk. Okay, so social, smoking, alcohol, driving, and then like any genetic disorder, okay, have you got any siblings? Have you got any kids? If there is any sibling here, by the way, asking about siblings, do not ask about siblings. Don't you ever ask about siblings, only his kids, okay? Unless the surrogate asks you about his siblings, do not raise this issue. We will come to know why later on. But for now, history should include smoking, alcohol, social, driving, and then do you have any kids? Not do you have any kids. Do you have any, do you plan to have any kids in the future? Do you plan to have any kids in the future? Okay, if he tell you, yes, doctor, I am planning to get married soon. I am really keen to have kids in the near future. So as we have discussed, not as I told you, as we have discussed, there's a chance that your kids might get the condition, 50% chance. So I will refer you to the genetic counselor. There is some options to prevent the transmission of the disease to your future kids. This will be discussed with you in details with the genetic counselor, full stop. Do not mention the options as we have just mentioned in multiple endocrine neoplasia type 2. So these are for the examiners. Okay, so social, smoking, alcohol, driving, and genetic counselor referral if he is planning to get kids. Okay, if he tells you, for the instance, if he tells you, I want to screen my daughter, okay, or I would like to screen my brother, or I would like to screen my son. Here, I want to ask you a question. Will you advise him to go for genetic testing or not?
No.
Anyone have any idea?
No. Anticipation because of it.
Exactly. Actually, regarding genetic testing, there is a few points I would like to discuss. Okay, whether or not you should advise genetic testing will depends on two issues. Okay, the first one, you should ask yourself, is that condition treatable or not? Okay, for instance, in multiple endocrine neoplasia type 2, there is risk of developing cancer. We can remove the thyroid gland and prevent the development of cancer. Okay, cancer will endanger his life, so genetic testing is indicated. Okay, but in Huntington disease, nothing to be done. Genetic testing, whether tested positive or tested negative, nothing will change in the plan of management. You will just wait for the development of symptoms and then offer treatment accordingly. So the first thing you should ask yourself, is the condition treatable or not? Will the result of the genetic testing change the plan or not? Okay. The second question, is there any way to diagnose the condition other than genetic testing? Okay, for instance, a patient has got Hussam. Okay, you can simply do echo, right? Why on earth I should wait for the patient to reach age of 18 to sign an informed consent and to do the genetic testing? Okay, maybe he will die because of complication. Okay, so I have got simply echocardiography to confirm the diagnosis, so no need to go for genetic testing. The same for adult polycystic kidney disease. I can do ultrasound of the kidneys. Okay, there's some criteria of the cyst. I can diagnose polycystic kidney disease without the need for genetic testing. So the first question you should ask yourself, is it treatable or not? And the second question is, any other way to diagnose the condition or not? Okay, if the condition is treatable, okay, and there is no other way to confirm the diagnosis, genetic testing is indicated. It is strongly indicated. For the instance, patient who has got alpha-1 antitrypsin deficiency, okay, if you confirm the diagnosis and replace the enzyme, his general outlook will change considerably. He will not develop emphysema. He will not develop liver cirrhosis. So the management plan will change. You can offer enzyme replacement. Okay. So if the patient is suspected to have alpha-1 antitrypsin deficiency, okay, you did the enzyme assay and it was inconclusive. At this stage, you can do the genetic testing, and if positive, you can offer treatment. Okay. So if it is treatable and there is no other way to confirm the diagnosis, go for the genetic testing. Okay. For cases like Huntington disease and tuberous sclerosis, diagnosis is usually clinical. Okay. And whether the patient tested positive or not, nothing will be changed in the plan. Anyway, it is not treatable condition. It is not preventable condition. So no need to go for genetic testing. So in this case, in case of Huntington disease, in case you face this case in the exam, how to answer this concern? Okay, the surrogate will tell you, doctor, I would like to screen his sister. Please, I would like to screen his sister, doctor. Will you do that for me? Don't tell him, no, don't screen. You will hear a lot of drama. No, doctor, I would like to know his diagnosis. How come? Maybe she will develop the condition in the future. Blah, 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 blah. He will make a lot of drama. So do not tell him, do not go for the screen immediately. No, you should answer this way. Okay. Okay, Mr. David, before I give you my advice regarding genetic testing, let me explain a few points to you. Maybe you will be able to see the situation from different perspective. First of all, genetic testing has got false positive and false negative result. So if she tested positive, it does not necessarily mean that she will develop the condition. If she tested negative, it does not necessarily mean that she will never develop the condition. Second point, if she tested positive, you will never know when she will develop the symptoms. Okay. Now, after 1 year, after 20 years, you will never know. Okay. And then you will never know also how severe those symptoms are going to be. It might be really devastating, and it might be very, very minimal. So you will never know for sure whether you will develop the condition or not. You will never know when the symptoms will develop and how severe they will be. So she might be stressed and anxious over a disease which might never develop. Okay, she will have a lot of worries and psychological negative psychological impact over disease which might never develop in the future. Okay, so these are 3 points. One more thing, in order for his sister to go for the genetic test, she has to be within the legal age. Okay, she has to be able to understand the implications, advantages and disadvantages of the test. This test is life-changing test, especially for people who are suspected to have Huntington disease, because if you test it to be positive for Huntington disease, everything will change. Your life plans will change. Your job applications will be affected. Okay, your insurance policies will be affected. Okay, so it's a life-changing test. She has to be within the legal age, and she has to have the capacity to understand all the pros and cons, advantages and disadvantages, and has to be fully informed before she can sign a consent in order to go for the genetic testing. In her case, she is only 9 years old, so it is better to let her grow up into the legal age, and then she can decide for herself. Okay, so this is the way to answer the concern. And by the way, the legal age for signing a medical consent is 18. Okay, sometimes the patient might be 17 or 16 or even 15, but when you assess him, you will find that he has the capacity. I mean, he can understand all the information provided. He can weigh up the positive and negative, I mean, advantages and disadvantages, pros and cons. Okay, he can retain the information. He can reach a decision, and he can communicate this decision to you. So despite he is not 18 years of old, he is only 15, 16, 17. Sorry. So despite he's not 18-year-old, but he can sign the consent for himself. This we call them mature minor. Mature minor, they can sign the consent, but generally he should be within the legal age. So this is a way to answer the concern. Okay, false positive or false negative, you will never know when the symptoms will develop, how severe it will be. Okay, a lot of anxieties, distress, and psychological negative impacts. Okay, life-changing disease, insurance policies, future plans, job applications will be affected. So let her grow into the legal age, and then she can study her options and decide for herself. Okay. So this is regarding genetic testing. Usually, okay, for diseases in which there is another way to confirm the diagnosis, like Hussam and adult polycystic kidney disease. We mentioned that we can do echo for Hussam and we can do ultrasound for polycystic kidney disease, right? But there is some exceptions. Any rules has gotten exceptions, right? Rules are made to be broken. So in people with Hussam, we have got some exceptions when genetic testing is indicated. Okay, these exceptions are: first, patient has got a positive family history. Okay, he is symptomatic, but we did echo twice and it was negative. Okay, shall we just send him? You are okay, go. He might develop arrhythmia and die. So if he has got positive family history and he is symptomatic, there is a very huge chance that he has got Hussam, but not apparent in the echo. We have to repeat the echo. If negative twice, then go for genetic testing. The second situation, patient has no symptoms, but he has got malignant family history of sudden death. Okay, here, despite the echo is negative twice, but still it will be wise to go for genetic testing, because family history of sudden death increase the risk of sudden death. We don't want to take the risk. So he's asymptomatic but has got malignant family history, negative echo twice, you will go for genetic testing. The third situation is if the patient is doing, a pilot, for the instance, or army cap. I mean, he is involved in vigorous exercise, stressful occupation. Okay, and he has got a family history, but his echo is negative twice. On this situation, you have to go for genetic testing. These are the exceptions. Otherwise, imaging is superior to genetic testing. Did you get that? Hope genetic testing is clear so far.
Yes.
Yeah, I think these are all the points we need for genetic testing.
Dr. Hussam,
Yeah.
3 T's: thinking, behavioral changes.
TB. T for thinking, B for behavior, triple M, memory, mood,
and triple M, movement,
memory,
and
memory, mood,
mood.
and movement.
Mood
Yeah,
and memory.
movement is
And complication, worse prognosis, progression in course, anticipation, and
anticipation. Just this is enough.
just this. Okay.
Yeah. For the
Thank you
examiner,
so
if
much.
he asks you, you can mention problem with swallowing and speech, and then most of them will die at the age of 20 years after diagnosis by aspiration pneumonia. Okay, but no need to overload a patient with Huntington disease with lots of information at the first meeting, because already he has got a problem with thinking, problem with memories. So it is a silly thing to try and explain every complication which mentioned in the book. Instead, it will be more clever and more smart to provide him with brochures, websites, group support, and so on. Did you get that?
Thank you.
Okay, and just one more thing I would like to add for Dr. Fatima. Usually, you will recap the case in session 2. You are the one who are going to summarize the information, because the surrogate told you the information. So you will summarize the information to make sure that you did not miss anything, and if anything is to be added by the surrogate. But in case of Station 4, you will ask the surrogate to recap for you. You want to know if he has understood anything or not, if he has the capacity or not, if he was able to understand anything, okay? Retain the information and communicated back the information for you. This means that he has the capacity, okay? And that he understood everything you explained to him. So you are not the one who is going to summarize in Station 4. No, the surrogate is to be summarizing for you. And if he forgot anything, you can remind him, you can fill the gap for him, you can offer support, brochures, websites. Did you get that? Dr. Fatima is here or left already maybe? This session was too long really. Okay, so just the last points regarding examiner's questions. Whenever the examiner asks you, how do you think your scenario went? There is a fixed answer for that, fixed answer. Okay, you don't need to think to answer this. The scenario was challenging, but I did my best. I did my best. Don't think it was difficult or it was easy or no. I did my best. The examiner wants to know from yourself, your assessment. How do you assess yourself? It was challenging scenario, but I did my best. I explained everything. I explained the anatomy. I explained the pathophysiology, complications, clinical presentation, the cause, and I explained the management plan. I offered screening for his family. I did everything. I explained everything to him. So if the examiner was not focusing, was not concentrating during the scenario, he will know that you covered everything. Okay, sometimes he needs reassurance from your side. As soon as you tell them I did my best, he will start ticking for you. My examiner in my case asked me, did you mention the complication? Yes, I mentioned the complication. Then he did tick. Did you mention did you ask her about social history? Yes, I did ask about social history. Then he put the tick. Okay, examiner is human being. By the end of the exam, especially if your station is on the last at the end of the exam, the examiner is already tired, bored, and lost their concentration. So he will need some questions to make sure that you ask everything. So whenever he asks you, how did your scenario went? The simple answer, it was challenging, but I did everything. I explained to him, okay, and I did my best. Okay, then if the examiner thinks that there is something missed by you, for instance, you forgot to tell the patient about the complication, or you forgot to tell the patient about association or cause or whatever, or the management plan, or you did not stop the patient for driving, okay, he will ask you if you have the chance again to sit with this patient, okay, any aspect of the scenario you would have done differently. At this time, immediately you have to think about your 4 C's and the management plan and the questions you need to ask before the management plan in order to get the clinical judgment mark. And if you missed everything, you need to mention here. If I got enough time, I think it would have been appropriate to advise the patient to stop driving. It have been appropriate to stop the patient smoking. Okay, maybe I would have elaborated more in the clinical presentation or explaining the complications. Did you get that? As soon as you ask you anything you would have done differently, make sure that you are missing something. Go back and think about your 4 C's, the questions you asked for the management plan and the management plan, and if anything missed, tell him. As soon as you mention, he will give you your mark. He will know that you should do this, but because of the exam stress or anything, you forgot to do it. But you know it. You are a safe doctor. In real life, you are going to do it. Okay? He will give you your marks. Then he will go on and ask about the usual question, which is ethical issues and legal issues. Whenever it's about genetic testing and explaining diagnosis and so on, ethical issues are autonomy. They have the right to know, right? In case it was something like multiple endocrine neoplasia type 2, beneficence, the family has to be tested, and we should advise them to go for prophylactic thyroidectomy to prevent the development of cancer. So this is beneficence, right? But in case of Huntington disease, Okay, or tuberous sclerosis, non-maleficence here apply. Okay, genetic testing, okay, will not change the management plan. Okay, it will cause considerable psychological impact. Okay, the risk here outweighs the benefit, so it is non-maleficence to advise the patient to go for genetic testing. You do get that? So autonomy is fixed. Then if genetic testing is indicated, this is beneficence. If it is not indicated, this is non-maleficence to advise the patient to go for it. Okay. Then legal issues. There is a fixed legal issues, which is confidentiality. The genetic testing, by the way, it cannot be delivered to someone else. Okay, it has to be delivered to the patient himself in hand. It cannot be sent by email or by telephone or whatsoever, because confidentiality is the essence here. This is very important. Confidentiality, you have to mention confidentiality in any case which has got discussion about genetic testing. Okay, and the other point you can mention here is consent. Consent. Genetic testing needs consent. Okay, and legally the person, in order to go for genetic testing for Huntington disease, he has to be within the legal age, or he has to be a mature minor who has the capacity to make decision for himself. Okay, so autonomy, beneficence, or non-beneficence, then confidentiality, and consent. Sometimes you need to add driving also, as in patients with Huntington disease. By the way, driving is a legal issue because he is legally bound to notify the DBLE, and you are legally bound to tell him to do so. Hope everything is clear. I think I will stop here. This session was too long today. All of you are exhausted. I am, and I have almost lost my voice. So see you next session, inshallah.
Thank you so much, Dr. Hussam.
I hope everything is clear. These two topics, it's always a matter of debate and confusion. Hope everything is clear about it. And if anything is not clear, please do not hesitate to send any question in the group. I will go over the message and try to answer them. Okay. Goodbye.
Thank you, Dr.
Thank you.